Well, good morning. I am the first speaker of the day. Welcome to the Fredericksburg Regional Sports Medicine Symposium. This is our 20th year. So I'm going to be talking about fat pad impingement, that they're not all meniscal tears. So this is a topic that typically comes up, anterior knee pain, patellofemoral disease, teenage growth stuff, and I wanted to put a little bit of a spin on it and give you a topic that was a little bit more interesting. We could obviously spend a few hours on this, but this talk will be brief and will not get too much in depth, but I do think it'll introduce the topic for you. So, fat pad impingement. For those of you who don't know me, my name is Mark Ford. I am a physician assistant, trained in orthopedics. Did a little bit of emergency medicine way back in the day, but primarily came up through the athletic training ranks. Back at James Madison University, I went to PA school at Wake Forest University. I have a bunch of credentials that you really won't care much about. I've got a master's degree at Nebraska. I did the Olympic Training Center back in the 90s. I serve as an adjunct professor at several of the PA programs and do precepting. And I have spoken at the conference a couple of times, but actually usually I'm doing the directing and not the talking, so I'm back on the podium today. I love my family. I'm very active at my church at Life Point, and then for those of you who know me well, my biggest hobby is hiking and backpacking. So I'm all over the country, and as of next year, all over the world, running around. So this is Moosilauke up in New Hampshire, one of the higher mountains, and I caught it on a good day. So my talk is the grade talk for the attendance purposes. So is that gray, G-R-E-Y, or is it gray, G-R-A-Y? So if y'all don't know the trivia there, you can look it up later, but they're both correct. I have only one disclosure, which is that I am the founder and owner of Precise Education, but as we've spoken about before, this is essentially nonprofit, and all of our money goes back to charity and the symposiums that move forward. We have a couple objectives that you can certainly read on your own, but we're going to talk about fat pad impingement today. More importantly, why are we talking about this topic? So why did I bring it up? In my orthopedic practice, I see a lot of sports medicine, obviously, and a lot of anterior knee pain. And we are seeing higher rates of fat pad impingement. And there's several reasons for that, which I'm going to get into in the talk. But the physical therapist in this room will certainly be very comfortable with that diagnosis and see a lot of this type of pain, but our athletic trainers in the group may or may not. So fat pad impingement is a diagnosis, and there are a few reasons that it can occur. So the real reason why I wanted to present this topic was to at least introduce what it is and how it looks like, so you don't just miss it or think that everything on the anterior or the medial aspect of the knee is patellar tendonitis or medial meniscus tears. So I'll give you a couple tidbits to try to pick it out on, and maybe some patient stereotypes that are a little bit more common, and then just as importantly, how you can manage it and treat it moving forward. So let's get into it a little bit, and let me give you a little bit of an anatomy lesson here. So this is an MRI of the knee. It's a lateral view. So let me get you oriented here. So this is hamstring muscle belly back here. Here's calf muscle belly down here. This is the anterior aspect of the knee. Here is our quadriceps tendon, the patella, which is embedded within the quadriceps tendon, the patellar tendon that comes into the tubercle. This is the growth plate, or the growth plate almost remnant at this point. This image is a little bit more central, but these are the horns of the meniscus, these black little triangles. As you get further lateral and medial, they are usually a little bit more crystal clear triangles. Again, remnant of the growth plate here. This is a vein in the back of the knee. You cannot see the ACL and PCL for the cut that I took, but what I want to demonstrate to you or show you is the fat pad. So if you look here, this structure that sits underneath the patellar tendon and in the anterior aspect of the knee is the infrapatellar fat pad. There's very little fat, but a little bit of synovium that sits up underneath the kneecap, and then you get synovial and fat tissue that sits suprapatellar as well. The tissue out in the front, anterior to the patellar tendon, is the prepatellar bursa. And in this image, you see adipose tissue, which is obviously fat and skin. So that's your anatomy from a side view. If you look at it from an anterior view, if you mash on the patellar tendon, that kind of bulgy stuff that goes out on the medial and lateral aspect around the patella tendon is the infrapatellar fat pad. That is a normal finding. Now, some people will describe swelling to the infrapatellar fat pad. Really, the fat pad doesn't get swollen. What you're getting is an effusion or fluid within the knee joint that produces swelling within the knee, and then that effusion pooches out the fat pad, both medial and lateral, in the soft spots. So they get these kind of bulgy, poochy things. That's actually the fat pad. It's not really necessarily swelling. So patellofemoral joint up here in the front, patellar tendon, menisci here, or the anterior and posterior horns of the menisci, infrapatellar fat pad here in the front, which we also call Hoffa's fat pad. That'll be important to know because the infrapatellar fat pad, Hoffa's fat pad is the same thing. So those will be kind of the structures that we're going to be talking about today. So if you do a case review and pull the literature on Hoffa syndrome or infrapatellar fat pad impingement, I think you'll be a little bit surprised, and it's really the other reason why I wanted to produce this talk here. So there is a lot of literature about infrapatellar fat pad impingement or Hoffa syndrome, but I'm not sure if a lot of that data is really relevant at this point, because clinically I certainly see a different category than what we talk about primarily in the literature. So if you talk about the epidemiology of fat pad syndrome, one is patellar alta. Alta means high riding patella. So if you look at the insole ratio of patella alta is a risk factor for fat pad impingement. Trauma is the next, so repetitive blows and repetitive pinching of the tissue will cause inflammation and irritation of the fat pad. That's not uncommon, and I don't necessarily disagree with that. And then the microtrauma of day-to-day activities is the third one, which we're going to spend a little bit more time on. Interestingly, most of the studies that we talked about, that are talked about with fat pad impingement, really relate to the soldier. So, and which is not a surprise because sometimes a lot of our data comes out of military institutions. So, fat pad syndrome, infrapatellar impingement was studied at high rates with our military forces. Now, our data is a little bit unclear. Is that because you've got a couple of military doctors that have high rates of MRI and are able to pick this diagnosis up, and it's an ICD code that they put in, but most of our data is with soldiers. Runners is the next large group. So we've got a lot of studies looking at runners and getting fat pad irritation and fat pad impingement, and the third is cyclists. So if you pull our data, that's where you're going to get most of the information regarding fat pad impingement. But what I want to talk a little bit more about today is really this little girl over here, because by far the more likely findings for fat pad impingement in clinical practice in this day and age is this young teenager with patellar instability, patellar dislocations, ligamentous laxity, Q angles, abnormal foot structure, who present in my clinic ages 10 through 16, 18 even. This is by far the majority of my fat pad patients that we see. And I think truly the literature just hasn't caught up to us yet, because most of our studies are looking in the past. Once we start looking at young ladies and fat pad anterior knee pain, I think you're going to see a lot of this reported in the next several years. I wouldn't call it a fad, but just like hip labrums and femoral acetabular impingements and rotator cuff specific diagnosis, we tend to see things come in cycles. And I think the next cycle you'll see when we talk about fat pad impingement is going to be teenage girls. So now we're talking a little bit more about the patients that we typically see here. This is the classic presentation, and it's not just this one, but this is by far the more common patient that's going to walk in with fat pad discomfort. But let's talk a little bit about the differential diagnosis. So when we talk about anterior knee pain or knee discomfort, there are several things in the knee that we have to address. A lot of them are pretty basic, and a lot of them can overlap to some degree, but if you kind of work through them specifically, I think you're going to be able to narrow down your differential diagnosis. What I always tell my athletic trainers, and really my students and anyone that I work with, is don't try to shove a diagnosis in a box that doesn't fit in the box. So if your differential diagnosis is built and your clinical exam and your history taking doesn't agree with that diagnosis, then shuffle it out of the box and keep working towards the next one. In other words, don't try to make everything a medial meniscus tear when the pain is on the medial aspect of the knee. There are other things that can be the cause of it. So when we talk about knee pain, specifically anterior, we can talk about prepatellar bursitis, fluid collections in the front part of the knee. And that typically would give you soft, fleshy fluid that's fluctuant and superficial. It can be red, it can be irritated. It's usually from direct blows and or somewhat repetition. Patellar tendonitis, if you're looking at an age category where they're getting growth cycles still, they can get inferior pole patellar tendonitis and get really focal pain at the inferior pole of the patella. That would be different than necessarily into the fat pad structures. And then if you're in hardcore activities, basketball, volleyball, jumping, plyometrics, racquetball, tennis, where patellar tendonitis would be a much more common diagnosis. And don't forget all the plyometric workouts in the off season. Patellar tendonitis starts to rise to the top a little bit more. Meniscal tears, so this talk is about not meniscal tears, but you have to keep that in the differential diagnosis, obviously. But meniscal tears as a whole are relatively straightforward. The one finger sign, middle finger or medial joint pain and lateral, but when you can put your finger on the joint line and make it hurt, when you can reproduce symptoms with deep flexion, McMurray's type maneuver, Apley's compression, distraction, all kinds of the studies that we obviously name, but those are usually pretty focal. And when we're looking at fat pad impingement or anterior knee pain, meniscal symptoms and anterior knee pain usually have a different clinical exam and should be picked out. Osteochondritis dissecans and or osteochondral defects. These can be a little bit more vague when we talk about knee pain, and I also think we can do a good talk on this as well. So osteochondral defects or dissecans, I'm using both terms, they're two different things, but two different diagnoses. So when we get articular cartilage injuries to the medial or lateral femoral condyle, these knees can be traumatic or they can be irritations and growth plate or growth cycle changes. Their exams can be much more vague. You can sometimes put your finger on it and make it irritable more up on the condylar region. They can have effusions, catching and locking that don't necessarily fall in the same category. There's something called the Wilson's test that you can do, but osteochondritis dissecans is typically picked up on x-ray or MRI, but you have to keep a suspicion for this. This is going to be a deeper seated knee pain. Post-surgical scarring, which can go hand in hand with fat pad irritation with people that have had previous arthroscopy, ACL reconstruction. As a whole, we're driving those scopes in and through that infrapatellar fat pad. So post-surgical scarring certainly can be a risk factor for anterior knee pain. And then patellofemoral syndrome. Now, as you know, a syndrome is a generalized term, so patellofemoral syndrome is going to be a pretty wide encompassing differential right there. Patellar instability, patellar compression, lateral tilt, chondromalacia, lateral tracking, all those can fall into that category as well. And when we talk about this topic today, I'd like you to think a little bit about those diagnoses hand in hand rather than necessarily separate, but there are some things that we're going to tease out the difference between them on. Okay, so let's talk a little bit about fat pad impingement. So let me get you back in some anatomy here. So fat pad impingement can occur in multiple locations, but here's our same model we showed earlier. Here's the infrapatellar fat pad, and in this sequence you're seeing edema or inflammation within the infrapatellar fat pad from getting impinged. So what are the symptoms to this? Again, they can be relatively vague, and it may be the presentation that causes it. If you follow our literature, burning and aching symptoms in the anterior part of the knee, pain when they're fully extended, so when that knee goes all the way straight, they're then going to lock that tissue or irritate that tissue in the patellofemoral joint. That can cause them pain. And then if they're in a prolonged flex position, so that tissue is kind of getting smashed and is under tension, they can get ache and discomfort in that area as well. So it can be a little bit more vague regarding positioning. They can get sporadic popping and catching. So when they are moving, or if they're contracting their quad or getting that patellofemoral joint to mobilize, sometimes they'll feel something thunk, pop, rub, or click inside the knee. That's not an uncommon one. So once again, here we are talking about popping and clunking in the knee. So now that differential includes meniscal tears, patellofemoral shifting, and fat pad catching. All those could certainly be the cause. So snapping is another one that's more common. They actually can feel it click or snap, and it's usually associated with pain, but doesn't necessarily have to be. And then they get that kind of puffy, swollen knee. So the knee will look a little bit more prominent. That fat pad can be a little bit more swollen in the front. The knee just seems puffy and irritated. I tend to think of this, again, more like those puffy, swollen patellofemoral patients, more so than large effusions. So even though they don't have those big cantaloupe knees, the patient will demonstrate a sense of it's puffy and swollen, even though it doesn't necessarily look that way. Now, with some of the more mechanical fat pads, they certainly can also get effusions, and we definitely see them. They're a little bit more uncommon, though. So if we move into our clinical exam, what are we going to see? And once again, like I said, we build differential diagnoses. I think that's the best way to do it, and then start to rule things in and rule things out. So they certainly can have tenderness focally right over the anterior medial or anterior lateral fat pad. The patients that are isolated with this diagnosis aren't going to have necessarily tenderness over their patellar tendon, medial lateral joint line. So look for some tenderness. Sometimes it can be rather generalized, though. We talked a little bit about swelling physically in the knee, and then effusions more predominantly in the knee. But also check out your Q angles and alignment. So do you have that awkward valgus knee? Do you have the knee or the foot and ankle structure that's really pronated when they stand? In other words, is that knee alignment typical for them? And then I want you to pay a little bit more attention to patellar instability in these patients. So once again, many things that can cause patellar instability, but if that patella is gliding and hypermobile, then you've got a little bit of increased risk of catching and grabbing that tissue as it comes through those range of motion arcs. And then, as we talked a little bit about before, your pertinent negatives. If the patient doesn't have any pain with deep flexion McMurray's maneuver, their ligamentous exam is stable, and their patellar tendon is non-tender, but they describe continuing anterior knee pain, put this back in your differential diagnosis. It may be the source of it. Use your skills to rule those diagnoses out just as much as rule things in. So for testing, we do have some tests. One is called the Hoffa fat pad test. And really what you're doing here is just grabbing a hold of the knee and putting your thumb or just mashing on that fat pad. You can push it medial or lateral and then do both. And then move that knee from 30-40 degrees of flexion into full extension. So you're straightening the leg out while you're mashing on the fat pad. And if you're pushing on that fat pad and impinging it into the trochlear groove and up against the condyle, and you elicit pain, or you are eliciting mechanical symptoms like a pop or a catch or an apprehension, then you have a positive Hoffa fat pad test. I always encourage you to do this with the other leg too, so this is a good contralateral test to check, because if they hurt all over and every test is positive, then your testing doesn't really help you much. The other one to do is when the knee is in full extension, you can do an isometric quad contraction. So just make them tighten up that quad. And if they get infrapatellar pain with that, you may have irritation in the fat pad area. This is also a great test to look at quadriceps atrophy, tone, VMO. You're doing this in your alignment check. You can add that into your patellar hold and grind. So not something that we don't already do, but where are you eliciting discomfort and pain when you're checking that? And then from a objective study, your x-rays are going to help us a little bit with some patellar positioning, but MRI findings are really the gold standard for finding fat pad impingement, because just like that previous MRI that I showed you, they're going to have edema, fluid, and thickening within the infrapatellar fat, and then you know that's your diagnosis. The problem with that is I see a lot of MRIs that have infrapatellar fat pad fluid but don't have any anterior knee symptoms. So there's a lot of false positives on that MRI finding, but our MRI really helps us to confirm our diagnosis. Okay, so what are we going to do now? So we've ascertained maybe we've got fat pad impingement. We've ruled out some of the other diagnoses, and we're going to try to treat these symptoms. Well, here's where it gets tough, guys and gals. We don't really know. It is a difficult problem to treat. I have been seeing this in the clinic for years. I queried multiple physical therapists even before I did this talk. We've pulled literature in our data regarding this, and there really isn't a one gold standard way of fixing this problem, and that's probably because the problem is secondary to another primary issue. So I think the best advice I can tell you is we've got to fix the underlying problem. And what I would recommend to you today is that most of these issues, especially in the population that we're seeing in the sports medicine world, a lot of these are going to be patellar instability, hyperlax knees where that tissue is getting caught up. And if you treat that problem, then our fat pad impingement will probably go away. So what's the gold standard there? Well, as a whole, usually physical therapy. Physical therapy to stabilize the patellofemoral joint is probably going to be your best option for decreasing this issue. Now, how do we do that? That's where it gets a little bit more complicated. We just talked about positioning in the knee and coming into full extension can impinge. So there are physical therapy protocols for taping to try to work on rotational stability of the patella. We do a lot of mid-arc work so that knee is not getting impinged in full extension, but yet then we're missing out on our VMO and our patellar stabilization that comes with that. Bracing options aren't really necessarily very good either. There are some patellar tracking braces that can be worthwhile, but as all of you know in the room, most of our patellar braces are providing biofeedback and a sense of stability rather than truly structurally correcting any lateral tilt or patellar instability or motion. But using braces like that can be very helpful for a biofeedback standpoint and to promote confidence, especially in the training modes as we try to get that patellofemoral joint to work a little bit better. So what if it's not the patellofemoral joint and or what if it is? When they get to my office, what other options do we have? I definitely treat them with a round of anti-inflammatories, so over-the-counters and or prescription NSAIDs can be very helpful. I haven't had much benefit in using the over-the-counter topical creams like Voltaren arthritis or what's generically called diclofenac gel. I just think the infrapatellar tissue is just too deep for that, but it may be very worthwhile for some bursitis or patellar tendonitis. Sometimes when they have failed physical therapy, stability, just have exquisite knee pain, I'll provide an intra-articular or an intra-fat pad corticosteroid injection. Sometimes by getting some medicine right into the fat pad, I can decrease irritation, but that's not going to last if I haven't fixed the underlying problem. But we can sometimes use that for therapeutic and diagnostic benefit. So there's a little bit of literature with using PRP and stem cells, so using something that doesn't damage the articular cartilage like cortisone does, but our data is nowhere near presentable regarding that. But this is maybe one of those circumstances where using lidocaine or marcaine anesthetic blocks may be worthwhile in avoiding cortisone for diagnostic purposes, or maybe PRP to stimulate an inflammatory reaction, kind of seal and heal things back down, but there's really no literature regarding that. And then the surgical options for it. So our data does describe debriding out the fat pad, so going in there with the arthroscope and trimming back that infrapatellar fat pad so it doesn't get pinched into the knee. And that can be helpful. Some of the doctors are providing this with medial patellofemoral ligament reconstruction because, again, if the problem is patellar instability, you've got to stabilize the underlying problem. So performing MPFL reconstruction and debriding out the fat pad sometimes can be helpful. There is some data to suggest that MPFL and just handling the patellofemoral joint and the fat pad doesn't need to be debrided is reasonable as well. But these results are variable. So as you know, our gold standard treatment for this problem is going to be PT stabilization and non-surgical management. Try to avoid the operating room, especially in those 12-year-old little girls that are probably going to get better. Sorry about the awkwardness of that last pause here. Here are the references for the talk. There is a lot of literature out there, but again, you may find that a lot of it is old or maybe not the patients that you're relating to. Once again, I just want to thank you. I know this talk was relatively brief and maybe even a little bit superficial. My goal is just to bring the topic into light for you and start thinking a little bit about Hoffa syndrome or fat pad impingement. It is definitely out there. Try to tie that to your patellofemoral exams and see what you come up with. And physical therapists in the room, athletic trainers in the room that have learned how to treat this well, we would love to hear from you. Once again, thank you, and I hope you enjoy the rest of the talks.